Well, hello there. My name is Charlie Lees. I am a consultant gastroenterologist and professor of gastroenterology in the Edinburgh IBD unit. It's a great pleasure to be there with you virtually today to talk to you on my topic, which is the causes and consequences of inflammatory bowel disease. Here are my disclosures, and I would like to, in particular, acknowledge UK Research and Innovation, who are my major funder. So Crohn's disease and ulcerative colitis are the two major forms of IBD. We see this chronic, incurable bowel inflammation with really a dysregulated mucosal immune response with environmental and genetic triggers that seem to be mediated through this dysbiotic microbiome. We see these relapsing and remitting periods, which are very unpredictable, but typically uncontrolled inflammation leads to progression over time. There is usually the need for medical therapy, often the need for major surgery. And as we are here today, in the second half of 2021, despite huge progress, we still have many unanswered questions and an urgent unmet clinical need. So if we look at an individual patient who develops inflammatory bowel disease, we can plot out this relapsing and remitting course over time. All too commonly, we see the disease evolving top right, as I will go into in detail. For an individual patient, this means gut symptoms, as you can see here, diarrhea, bloody diarrhea, abdominal pain, nausea, vomiting, weight loss, and low appetite. We see significant extra-intestinal manifestations in a significant minority. So joint pains, skin rashes, eye problems, mouth problems, liver disease. We also see very significant psychosocial morbidity, ranging from anxiety and depression to poor sleep to dietary restriction. And this can occur especially during periods of flare, but also during periods of remission. And with uncontrolled disease, we see the disease progressing over time, particularly in Crohn's disease, but also in ulcerative colitis, with fistulas, strictures requiring major surgery, often with the need for a stoma, where we exteriorize the bowel contents into a bag on the abdominal wall. With repeated surgery in Crohn's disease, patients suffering from a short gut and needing intravenous feeding, and other complications of the disease and of the drugs that we use over time. So for an individual patient, this impact can be immense from the physical aspects and the psychological aspects I've described, as well as the long-term complications, but also on the everyday, spending more time in the bathroom, impact on studies and work, including absence and choice of job, relationships, sexual life, family life, and planning, regular medications required to maintain remission, and food choices that may be restricted. The global epidemiology of IBD is fascinating. It was very uncommon before the start of the 20th century. We've seen it emerge in the Western world, and then as other countries have adopted a Western lifestyle, we have seen this real explosion of IBD across the rest of the world, particularly in the Far East, in the Indian subcontinent, and soon to be in the African continent too. Well, I work in Edinburgh. Edinburgh is part of the Lothian county. The NHS Health Board is NHS Lothian. We have a population of around 900,000 people. And in the last 2 or 3 years, we've worked really hard to document every single person living with inflammatory bowel disease within the Edinburgh area. And as of August 2018, we documented a point prevalence of 7,000 cases, or 0.78%. In other words, 1 in every 125 people in Edinburgh living with IBD today. When they are diagnosed, our patients are typically young. You can see here, teenagers, 20s and 30s, but IBD can occur at any age. Importantly, the current age of our cohort is very much older. So our IBD patients now typically have multimorbidity and polypharmacy to contend with, as well as IBD itself. We have shown that over the next 10 years, the prevalence of IBD is going to increase and will be greater than 1% within 2028. And this is because we are in this era now of compounding prevalence. This third grouping along here, we have stable incidence rates, but we diagnose more people each year than die by about fivefold. So in Edinburgh, we see about 300 to 350 new cases per year, roughly one a day. We see somewhere in the region of 58 people dying with IBD each year. And so we're accumulating more and more cases. In the Far East and in the Indian subcontinent, we're in this accelerating incidence phase, and Africa is in this emergent phase. So what's going on? Can we get clues here as to what causes IBD in the first place? And indeed we can. We can see from these epidemiological data that there must be strong environmental drivers. We know from experiments that there is this altered microbiome, and we know very clearly that there is a strong genetic influence. So the environmental drivers, we can see if we go all the way back to our closest living relatives and filling in the gaps in between to understand that we now have IBD relatively commonly, but with the exception of cotton-top tamarins, monkeys kept in captivity who develop colitis, we don't see this in primate ancestors, and we don't think we saw this particularly commonly, although it probably did still occur occasionally in ancient man. And that's probably to do with our environment and our gut microbiome. So our environment is, of course, very different, and these are some of the factors that we know associate with the development of disease and are probably important in the development of complications. So diet, pollution, additives, hygiene, antibiotics, smoking, surgery, stress, exercise, geography, travel, sunlight, and vitamin D all seem to be important environmental factors. And of these, diet is the most compelling, and we're decreasing to build an evidence basis around things like low omega-3 fatty acids, low omega-3 fatty acids associated with increased risk, increased saturated fats associated with increased risk, increased red meat, sugars, emulsifiers associated with increased risk. Most recently, a paper in the BMJ this year suggested that high consumption of ultra-processed foods was associated with an increased risk of developing Crohn's disease. So this is giving us very important clues as to what's happening with disease onset. A couple of examples. So if you take animal models with a high fat, you see high bile acids, you see an altered microbiome, and then in genetically susceptible mice, you see colitis. We see emulsifiers in mice driving the development of colitis in a very strong and meaningful way. And we think that looks to be an important contribution to the development of both Crohn's disease and ulcerative colitis. My research career has been primarily based around the genetics of IBD. We've now documented well in excess of 300 independent susceptibility loci for IBD. We expect this number to at least double within a year as we do a next round of very large GWAS meta-analysis. We see multiple pathways of interest affecting the epithelial barrier, affecting adaptive immunity, innate immunity, and Crohn's disease, including autophagy, pathways relating to microbial sensing, and also biocidal mechanisms too. Very strong implications here, and strong leads into disease biology, leading to disease targets for treatment. JAK-STAT signaling, tofacitinib, JAK1 selective inhibitors coming, IL-12, IL-23 inhibitors. So we've got ustekinumab now, we've got risankizumab and gazelkumab and mirikizumab coming. Anti-integrins such as vedolizumab. It's fascinating to see how the genetics is really starting to come into its own. The microbiome is no less fascinating. We do have a challenge here because we see that the dysbiosis is present when people have disease. But a lot of this is driven by the inflammation that's present and the drugs that we give our patients. We need careful longitudinal cohorts of people before they develop IBD to truly unpack what's going on in the microbiome. It's fantastically complicated, the gut microbiome, and we're only scratching the surface of what we really understand. But there is no doubt it's very important in IBD. So genes, environment, and microbiome together, these give us Crohn's disease and ulcerative colitis, very heterogeneous phenotypes, which is a challenge as well as a joy, of course. The big challenges come in the clinic because we see treatment failure and disease progression commonly. So people have relapsing and remitting disease with periods of flare and remission, but in the background, importantly, this is leading to progression to complications over time. Let me show you this again. So periods of flare and remission, this is symptoms. But in the background, if we don't treat the inflammation properly, we see progression of bowel damage, irreversible changes, strictures, abscesses, fibrosis, leading to complications of disease. And for all too many patients, this means major surgery, maybe the whole colon or part of the colon removed. In Crohn's disease, segmental small bowel resections, usually on multiple occasions and often leading to stomal formation. These are not conditions without a significant impact, particularly if we don't treat it effectively. And for the large part, we've had a problem in IBD because we haven't had good predictive models to help us understand who will get disease, when they've got disease, who will have an aggressive versus a quiescent disease course, who will flare, and who will develop the complications of disease. And this is a major part of what my research program is undergoing. So at diagnosis even, we don't know who will undergo a quiescent disease course. We know that about a third of patients, when you look on a population level, will have a relatively benign disease course without the need for advanced therapies such as biologics. But the majority will have relapsing remitting disease, and in particular in Crohn's disease, the evolution of complications over time. So if we could, at diagnosis, stratify by risk by identifying risk factors for progressive disease, and now, as I'll show you, that we have multiple different drugs working via different modes of action, stratify our patients by biology, we would do very much better. We're not completely blind in the risk, but I'll show you that we're quite limited at the moment. We have a number of very good treatment options available now, but we're slightly blind about working what drug for what person at what time. The bottom right bit is the mechanism that we've developed to get around our deficiencies in point 1 and 2. We now treat to target by starting therapy, monitoring with symptoms, blood, CRP, stool markers, calprotectin, endoscopy, biopsy, and imaging, and we adjust therapy till we hit the targets to make sure that we can get our patients well. If not with the first drug, then at least with the second drug. So I mentioned that Crohn's disease is particularly a problem. We see that most people present with purely inflammatory disease, that's B1 here in the yellow, but most over time will develop blue or red here, stricturing or penetrating disease. And our drugs are anti-inflammation drugs. And so that means we have this inflammatory window of opportunity early on when we are best to intervene in Crohn's disease. And we now have a range of effective agents that allow us to do this. And this is relatively new. We've had anti-TNFs for 20-25 years, but now they are really affordable with biosimilar anti-TNFs. We now also have vedolizumab, an anti-integrin, ustekinumab, an anti-P40, which drops IL-12 and IL-23. And we have some very exciting drugs coming through late-stage development. P19 inhibitors specifically targeting IL-23, in particular mirikizumab and risankizumab, and oral selective JAK1 inhibitors, upadacitinib and filgotinib in particular, that look very exciting. So how can we use our existing drugs better, and how can we avoid the complications of disease? Well, let me walk you through this really important piece of data from our unit in Edinburgh that demonstrates what happens on a population level over the last 20 years with Crohn's disease. We divided our cohort into 4, from 2000 to 2004, 2005 to 8, 9 to 13, and 14 to 17. And on the left, you see surgical resection rates. And you can see that many people come to a surgical resection after 5, 10, 15, 20 years of having IBD, having Crohn's disease. You can see that these surgical rates have got lower over time and that the time to first operation has got longer. And that's because we're now using our biologics earlier. So on the right, you see the time to first biologic. You see patients in the blue, in the oldest cohorts, were very slow to start on a biologic. And you can see in the most recent cohort in the purple that we're using biologics much earlier in the disease course of Crohn's disease. This is demonstrated simply by use of adalimumab here. You can see with the originator Humira, it increasing over time in anticipation already of switching to the biosimilar adalimumabs in 2019 and 2020. In fact, we've been very big fans of biosimilars because we've seen that with all of our auditing over 4 different major phases here, from the initial infliximab switches to adalimumab switches to a second infliximab switch, and we're now undergoing a third infliximab switch, we're seeing that we have safe drugs that are as effective as the originators with massive cost savings that has enabled us to use the drugs earlier and more effectively. And indeed, if you look at all the phase 3 trial data for anti-TNFs in Crohn's disease, when you start the drugs earlier in the disease duration here on the left, you see higher rates of clinical remission in these studies. Interestingly, we don't see this with ulcerative colitis, but it is a clear effect in Crohn's disease. Now, I mentioned already that a third of Crohn's patients will have a quiescent disease course. How do we pick them out? Well, it's very hard at diagnosis. But if you monitor calprotectin aggressively in year 1, that gives you a marker of inflammatory status. So we followed up our patients in the long term to see whether or not normalization of calprotectin in year 1 affected long-term outcomes, and it's very, very striking. If you normalize calprotectin in year 1, in the blue line, you have far fewer disease progressions, surgery, hospitalizations, Montreal disease progression over time. Whereas if you don't, you do much worse. And the strongest predictor of normalizing your calprotectin is early biologic use in the first 3 months. But not everyone needs that, so if you monitor calprotectin, you can pick that up. Let's switch to ulcerative colitis. Ulcerative colitis, we have a major revolution on our hands because prior to 2014-15, we used virtually no biologics. This is population-based Lothian data from our cohort. We used virtually no biologics with the exception of infliximab for acute severe colitis. Now we use more. This takes you to 2018, 2019 and 20. You add to this tofacitinib and ustekinumab and it gets even greater. And with that, what have we seen? With that, we've seen that surgical rates are going down. So this isn't necessarily early in the disease course in UC. It's at any time point. We know that if you intervene expediently when a patient flares, you help to avoid colectomy. So colectomy rates have dropped as we've been using more biologics in UC. So let's just have a think strategically about how we can get our patients better. If we could stratify by risk, treat by biology, and prevent disease flaring, we could achieve a huge breakthrough for our patients. And we, I think, can do this with a lot of our IBD patients now, with our existing toolkits, if we intervene early in Crohn's disease and early in disease flares in ulcerative colitis. Unfortunately, as I've already mentioned, we're not brilliant at stratifying by risk. In Crohn's disease, we know a few factors: young age, smoking, extensive small bowel disease, perianal disease, weight loss, deep ulcers. But this has been a bit stuck for 15 years or so now, and we are hoping that precision medicine approaches will get us much closer to this over the next 5 years. From these other bits, we're having to think really quite carefully now that we're in the multi-drug era about what drug to give. So right patient, right drug, right time. How can we get there? And there's some really fascinating questions that are beyond the scope of this talk today to unpack. The role of precision medicine versus head-to-head studies, what drug first versus second, role of biosimilars, antibodies versus small molecules, and combinations of therapies. Anti-TNF drugs are definitely the cheapest. They are amongst the most effective, We still use infliximab and azathioprine in fistulating and extensive small bowel Crohn's disease. We still use it in acute severe colitis. But we do see immunogenicity with anti-TNF drugs over time, so patients lose response. This is a big problem, and we've seen this time and time again because immunogenicity decreases drug levels, it reduces effectiveness, it increases infusion reactions, and therefore leads to treatment discontinuation. We have made a breakthrough in the last year, though, with a very large genetic study called PANTS with 1,500 IBD patients, and we have identified a strong association with an HLA haplotype on chromosome 6 that is strongly associated with time to antibodies against both infliximab and adalimumab. And this is really, I think, a very exciting development and might enable us in patients who carry this risk haplotype, HLA-DQA1 star 05, to start with a non-anti-TNF based strategy and save us from some of the complications that occur over time. We've got so far actually as developing algorithms that help us here. So this is a real precision medicine approach to enable us to decide when to go ahead and use our cheapest drugs first, and when actually we'll be better off using our more expensive drugs first to be more cost effective and better for our patients in the long term. We have a very exciting few years ahead. Just this week at the UEG week, our big European gastroenterology meeting, we've seen a number of new drug targets come to light, specifically the P19 inhibitors and the JAK1 selective inhibitors. But we have already a number of different agents, and trying to work out what drug for what person can be in part, as I mentioned, a precision medicine approach. But actually we can also do this via randomized clinical studies, head-to-head studies of not just different drugs, but also biologic versus biologic. And there's two really key bits of data that we've gleaned in the last 2 years. The first was in ulcerative colitis with this VARSITY study that pitched vedolizumab with adalimumab in UC and showed very clearly on multiple endpoints that not only did both drugs work and work quickly, but actually that vedolizumab was much better than adalimumab in ulcerative colitis. And that has affected our treatment for UC patients first line. This is a very safe and effective gut selective agent that works best when given first line for UC patients. And then this year, we've seen the CView study in Crohn's disease, bio-naive patients randomized to either adalimumab or ustekinumab. And here, with a readout at a year, it was a real score draw. Both drugs working very well, both drugs working quickly, but you couldn't distinguish the drugs, particularly when you look on the bottom right at the primary endpoint of clinical remission at a year, both providing great options for our patients over time. So I'm coming towards the end now. We've stratified by risk, we've treated by biology. Even if we can't get this right the first time, we're doing our very best here, and we're then hopefully going to prevent the disease from flaring. This last bit has been a major research endeavor for us. I've been running the Predict study where we've taken 2,500 IBD patients in clinical remission. We've then looked a deep dive into blood, stool for the microbiome, calprotectin, questionnaires, and diet, and then compared people longitudinally to disease flare. So we want to see ultimately what's different in the baseline variables, particularly diet and the microbiome, in those people who flare and those who do not. We've got nearly all the patients to 2 years of follow-up now, and we're using this to look in particular at diet, environment, genetic variation, and the gut microbiota. We're really interested in total animal protein intake, dietary fiber, polyunsaturated fatty acids, and dietary emulsifiers, as well as the microbiome. So here we are really today. We're doing our best to stratify by risk. We're going to learn how to treat by biology, or at least via the results of head-to-head studies. We're really good actually at point 3 down here, treat to target and optimizing there. We can intervene early in Crohn's disease with effective therapy now at cost to get our patients better for the long term. We're doing better in ulcerative colitis too. This is a huge team effort. I've shown you lots of data here from the research team here, as well as from collaborators across the UK. IBD is a very exciting place. I want to say thank you very, very much indeed to you for your attention today. Sorry not to be there in person. I'd love to come and visit soon. Enjoy the rest of your meeting. Thanks very much and goodbye.